I've called this active surveillance from biology to bedside. Where have we come from? What are the issues? What's the future? So the thing about this topic is it really touches on very broad themes, from fundamental biology, molecular genetics of prostate cancer, progression events, to at the other extreme, screening, public health policy, overtreatment, costs, and then with everything in between, outcomes and so on. So I'm going to try and cover a lot of these issues. It's an overview. So the concept of overtreatment back in the mid-90s, when we got this whole thing rolling, was not rocket science. It had been recognized for a long time that many patients, that prostate cancer developed normally with age, that many patients were diagnosed, for example, in the TERP era with T1A prostate cancer. It was quite unheralded. These patients had histologic cancer, and yet they weren't treated, and this was not really remarked upon much when I was a resident. Somehow the whole issue of that they have a cancer diagnosis, you have to treat them, which became prevalent in the subsequent 25 years or so, so that idea was lost. So my group set out in about 1997 to try and deal with that, and we got together and decided to manage these patients expectantly, serial PSA, biopsy, intervene if it looked like something was not going well, like upgrading or rapid PSA rise. And this was a prospective trial. There was an informed consent. The language was quite alarming. It said, you are at risk of dying of prostate cancer if your disease progresses during the period of observation. And yet patients were really, many of these patients were very enthusiastic about the possibility of avoiding treatment. So we got a grant and set up a prospective database, and after about 5 years we had our first publication, which was 2002. 250 patients, no deaths, and then this started to get attention, and it was provocative. This did, no question, this hit the business model of urology in the pocketbook, but also I think there was a strong belief that the fathers of screening and radical prostatectomy, the Walshes and Catalonas, phenomenal giants in the field, but they were really committed to the idea that patients should be treated or they were going to die. So it was a battle, but the world came around. So now here it is 20 years later, and a lot has changed. So just to summarize that, much greater recognition of the overtreatment problem. So in the early days, this was not accepted, that definitely there was a problem of overdiagnosis and overtreatment. But I think since the task force recommendation 2011, no one really disputes that overtreatment is an issue. The nature of occult high-grade disease. So we didn't have a clue 20 years ago really what the distribution of disease pathology was in these patients. They had microfocal 6 on biopsy. Now we know that about 25% harbor higher grade cancer elsewhere in the prostate. The main significance of Gleason 6, it's a biomarker for that higher grade cancer, mostly anterior. The predictive value of baseline parameters, PSA density, race, extent of disease on the cores, keeps falling out as a predictor for that higher grade cancer. The flaws of PSA kinetics. So for the first about 12 years of this, we treated patients for a rapid PSA doubling time, and that was not a good basis for intervention because at least half of the patients had a spurious rise in PSA and probably were overtreated as a result. So we don't do that anymore. Multiparametric MRI, which we heard a gorgeous talk about, I'll speak about a little bit, is clearly a game changer. Modeling studies that basically show even if the mortality rate from the disease creeps up, that the quality of life benefits are very robust, and this is not going away. Some data on 5 ARIs, but particularly, I don't know if you can see that, this has become a hot area. I just did a literature search the other day, 2750 publications on active surveillance in prostate cancer. So every facet from the psychological aspect to the molecular aspects is being scrutinized. So just first a few brief comments about the overdiagnosis issue. And just to emphasize, I mean, we are visible in prostate cancer, but we're not alone. So all through medicine, due to well-meaning efforts to diagnose serious diseases earlier at a time when they're more curable, which is also what drives PSA and prostate cancer, the result is diagnosis in millions and millions of people of disease that otherwise they would not know they had. You drop the threshold for glucose to diagnose diabetes, hypertension, hyperlipidemia, osteoporosis. This is one of my interests, androgen deficiency. If you use a threshold of 11, about 20% of men over 70 and 30% over 80 will be diagnosed with hypogonadism, whereas really what they have is a normal testosterone decline with age. And many men potentially, and women overdiagnosed. And all through medicine, regardless of oncology, internal medicine, pediatrics, etc., you have this problem. So we are in good company here, and it's a malady of modern medicine. In the cancer area, there's 3 factors required for overdiagnosis: existence of a silent disease reservoir. We obviously have that with prostate cancer in spades. The so latent histologic disease. Roughly one's age is a diagnosis. One's age as a percentage is the likelihood of harboring prostate cancer, 60% of men in their 60s. Activities leading to its detection, namely PSA and its various iterations, and a long natural history with modest cancer-specific mortality. So this is clearly prostate cancer plus a number of others. And when you have a real epidemic of cancer, you tend to get this is the incidence and the mortality for these 5 cancers: thyroid, melanoma, kidney, prostate, breast. And it is with a overdiagnosis, the mortality rate doesn't track the incidence. It tends to remain flat or go down. And it is remarkable for these 5 cancers how the incidence has continuously tracked up over the last 30 years. The mortality has remained absolutely stable. Of course, that could represent better treatment, other factors, but there certainly is evidence of overdiagnosis in many cancers. And we talk about indolent disease. A topic that doesn't get much attention is actually cancer regression. And my understanding is in breast cancer, this is widely acknowledged, that due to absence of telomerase, VEGF, senescence, that tumors actually, in many cases, in fact, perhaps the majority, regress and disappear. And it's very plausible that is happening with some of these microfocal prostate cancers cases where repeated subsequent biopsies are negative. So it's not always just about implacable progression. So now to focus on the prostate cancer story, this, I would say, a consensus of what is agreed upon today, although there's many controversies. The first key point is that Gleason 3, although it occasionally has some molecular aberrations, 90% of Gleason 3 or grade group 1 cancers have molecular genetics that are essentially normal. Whereas pattern 4 has the molecular hallmarks, the Hanahan and Weinberg hallmarks of cancer. P10 deletion, you name the pathway, and it is much more likely to be aberrant. And the impact of that is the metastatic potential of Gleason 3 is basically 0. It is a non-metastasizing cancer, and that's a very key concept, and there is general consensus about this. The Achilles heel is the pathologic miss, the misattribution of low grade to a patient who's harboring a higher grade cancer, about 25% of these cases. In contrast to the prevalence of coexistent higher grade cancer, the biologic grade progression where 3 progresses to 4 or 5 is actually quite rare. And the best estimate of this comes from Ruth Etzioni, somewhere around 1% to 2% per year. So it's important. After 10 years, it's say 10 or 15% of cases, but much less of an issue, particularly early on, than the missed higher grade cancer. There are cases with prehistologic adverse genetic alterations. That's the basis for the tissue-based Oncotype DX and Prolaris. And finally, that there's a complementary role of MRI and biomarkers, although it's interesting that these two very disparate approaches of imaging and molecular characterization are trying to do exactly the same thing, which is identify the bad actors, predict either indolence or the converse. So they are, to a degree, in competition. And just some evidence to support, this is New England Journal, Tim Wilt's long-term update of the PIVOT trial, prostatectomy versus no treatment, just updated. And there's a modest benefit of prostatectomy in terms of overall mortality. But just to emphasize, this is the risk, the stratification by risk. And fortunately, this is slightly blurry from here, but you see the Gleason score. Sorry about that, I can't read that from here. The Gleason score at the bottom, yeah, here. You see the only real benefit is in the intermediate risk. The low risk, no benefit at all. The high risk, not much benefit, which probably suggests a lot of those cases are micrometastatic. And then a couple of studies that really demonstrate conclusively that the metastasis rate with Gleason pattern 3 is essentially zero. This Eggener study, 12,000 patients with 20-year follow-up treated with surgery, 0.2% prostate cancer mortality. So these cases have proven Gleason 6, grade group 1. No occult higher grade cancer that could metastasize, which you don't know about. And every one of these few cases who had metastatic disease after surgery were upgraded on re-review, and exactly the same phenomenon with this pathology paper from Ross, 14,000 cases, no confirmed Gleason 6 with nodal metastasis, 0 out of 14,000. So, how much more evidence do you need? And there's other papers, and I've asked many groups, does anyone here have a well-documented case of only Gleason 6 surgically confirmed that subsequently developed metastatic disease? I know of one well-documented case in Australia, and that's it. And, so you can say it doesn't metastasize and be very confident about that. Now, you do get these molecular aberrations. So this slide was shown earlier from Mark Rubin, and it shows the accumulation, the mutational load clearly increases from grade group 1, 2, 3, 4, 5. So it's not just a quantitative difference, there's a qualitative difference, there's a quantitative element. This is P10 here, but these isolated mutational events don't seem to confirm a metastatic potential. And there's just a very recent publication that showed in vitro that the P10 deletion required MYC amplification to actually acquire invasive potential. So that just makes sense, I think, that you need multiple mutational events before you actually acquire a metastatic phenotype, and that's probably the key to the non-metastasizing feature of Gleason 6. The other thing is that this is from Bruce Trock at Hopkins, showing that in patients who had Gleason 6 or 7, the ones who had P10 loss, which is one of the key events, almost always had elements of Gleason pattern 4. So sorry, that's not, just a sec. What did I do wrong here? My apologies. Slideshow. Play from current slide. Okay, sorry. So the pure Gleason 6 had somewhere around 3 to 4% P10 loss, whereas you needed elements of pattern 4 before you got loss of P10 in the pattern 3. Now, there's two explanations for that. One is that you are seeing a pattern 3 where there's a P10 loss is about to transition to higher grade cancer. It just hasn't shown the histologic dedifferentiation yet. And then there's this other well-known paper by Hafner of a patient who died of metastatic disease with Gleason 4 plus a tiny amount of 3. And to everyone's astonishment, they did deep sequencing of all these multifocal cancers in the prostate. The homology was between the low-grade pattern 3 and the bone mets, not the higher grade cancer. So how do you explain this? But the explanation I like is what we heard about earlier, and that is extracellular vesicle transfer. So this is a story, I'm not going to go into this because we heard a great talk about this earlier, but this is a form of intracellular communication. And the idea, it's been shown in animals that the higher grade cancer sends its either its microRNA that inactivates P10, or it sends its kind of aggressive phenotype inducing genes to the more indolent cells and confirms more aggressive behavior. So that's been demonstrated in animals. We heard about it to a degree in humans today, and I think this deserves a lot more attention. So if you accept that Gleason 3 is a non-metastasizing cancer, why do we get hung up on the volume? And every guideline, AUA, Ontario, ASCO, et cetera, differentiates between very low risk and low risk depending on cancer volume of Gleason 6. And the reason is that the volume of cancer is a predictor for the presence of coexistent higher grade cancer. And this is the wolf in sheep's clothing. So you've got the misclassification phenomenon and the grade progression. And if anyone's interested, to me, this issue of grade progression and how frequent it is very fundamental. And this is the best reference on this, which is in this obscure journal, Statistical Medicine, a few years ago, 1 to 2% per year. We've also done this kind of analysis, came up with a 1% figure. Hopkins has done the same thing. So you have 3 studies indicating, based on mostly serial biopsies, that the progression rate is low and in that ballpark. So to predict who has the higher grade cancer, you can use clinical predictors. This was just published from the Hopkins group using basically extent of disease, PSA density. I don't know if that can be focused at all, but anyway, maybe not. PSA density, age, and essentially various parameters that are surrogates for extent of cancer on the biopsy, number of cores involved. And actually, this is quite powerful. You can see the area under the curve here to identify the bad actors. And this is useful in terms of deciding who should have biomarker, who should have an MRI. So there's now about 10 prospective series in the literature. I'm going to focus on the 2 extremes, which are ours and the Hopkins group. And the reason I say extremes is we took an inclusive approach. So we included patients with all low-grade patients and selected intermediate risk, mostly 3+4. PSA could be up to 20. These were mostly, but not all, older patients. The Hopkins group took the opposite approach. You had to have Epstein criteria, only 1 or 2 cores, Gleason 6, no more than 50%. They treated patients who had volume progression. We didn't do that. So now we both have 15-year follow-up, and the results are quite interesting to compare. So first, our series, we had 22% intermediate risk, about 1/3 of them under the age of 70, and we have about 1,400 patients now in our cohort, but this analysis, which was published about 2 years ago, 1,000 patients, 30 with metastasis, 15 died of prostate cancer, and the rest are living with disease or died of other causes. And this shows the intervention rate. Now, based on what we know today, this is the wrong shape of the curve because it's too linear. We know the problem is not disease progression over time, it's the bad disease that they have right at the start. And really the curve should look like this, where we find the bad cases early on and then see the 1% to 2% rate of progression over time. So all the efforts at biomarkers and imaging is to really change the shape of that curve, and perhaps we'll end up intervening less frequently if we do so. This was a recent study from our group comparing intervention rates in 9 different cohorts around the world, which includes the Hopkins one, which I think is down here, and ours up here. But you see, it's all between about 20 and 30%. So the interesting thing is, no matter what your criteria for eligibility and intervention, around 25% to 30% of patients get treated at 5 years. And this is our overall survival out to a little over 15 years. Some of them patients have been followed for 20 years now. And cause-specific survival, with those 15 deaths, the actuarial mortality is 5% at 15 years. So amongst a prostate cancer cohort, my first reaction to that was, gee, we're doing pretty well. Of course, for those individuals who presented with low-risk disease, each one of those 30 patients with metastatic disease is a personal tragedy, but still, it's a small proportion of the overall group. We looked at if we could predict who those patients were, and what came out very strikingly was Gleason score. And what else is new? That it's predictive. But we selected these patients carefully. We followed them like a hawk. We knew the Gleason 7s were going to be at greater risk. And despite that, they had a 4 times greater rate of prostate cancer mortality just by virtue of having any Gleason 4 at baseline. And there were some of the intermediate risks were PSA above 10, but that didn't make much difference. It was all the Gleason score here, not the PSA above 10 in the intermediate risk group. And this is recursive partitioning analysis, so we break these down into their little subgroups. This is Gleason 6 on the left. All the Gleason 6 had 95% plus metastasis-free survival at 15 years, but as soon as there was elements of Gleason 4, on the biopsy at baseline, they had at least a 20% metastasis rate. And despite the fact that these Gleason 6 cases, some of them harbored higher grade cancer, but it was the presence of it on the biopsy had a huge impact. So we're now much more conservative with Gleason 7. There's clearly ways to do this. So this just came out of the Cleveland Clinic, just published within the last few weeks. Intermediate risk, smaller group, shorter follow-up. So I was showing 15-year follow-up. This is median follow-up of about 4 years. But they conclude no difference in metastasis, surveillance, failure, curative intervention compared to low risk in their intermediate risk group. So maybe you have to be very meticulous about patient selection. Obviously, MRI, biomarkers are going to play a role here. And then here's the Hopkins data, and they started theirs roughly the same time as we did, and they also have 15-plus year outcome, but with their very restrictive approach. I don't know if it was driven by fear of lawsuits, which we have much less of in Canada, or whether it was just philosophy. They weren't so sure about the surveillance concept, so they just restricted it to the best Epstein patients, and prostate cancer mortality 0.5% versus somewhere around 3 to 5% in our cohort, mostly representing the Gleason 7. So the benefit is fewer deaths. The downside is many, many fewer patients eligible for surveillance, probably a lot more patients being overtreated. So it's a classic trade-off of risk versus benefit. And there's been a convergence now. So the Hopkins group now acknowledges that most Gleason 6 can be managed with surveillance, not just Epstein. Our group is now much more conservative about the patients who have elements of Gleason pattern 4. We offer it to them, particularly the borderline 5 to 10% pattern 4, but now they all get an MRI, they all get a targeted biopsy, and a lot of them get some kind of tissue-based genetic assay. I think I'll keep going. So MRI, we heard about today. Here's a patient who had a elevated PSA in the in the 5 or 6 range, systematic biopsy, single core, Gleason 3+3. Today, he had an MRI, in the current era, and I don't know if you can see the lesion, but it's right up there. Imagine hitting that with a systematic biopsy. Impossible or unlikely. That was 4+3. He had his radical. There's the lesion, somewhat underestimated by the MRI, which is quite common, but 4+3 up here and 3+3 down there that was found on the systematic biopsy. So, this is just an anecdotal case, but it just gives you an idea of how the MRI is dramatically improving patient selection and early identification of the bad patients. This could well have been one of the guys in the earlier era who we followed very confidently, repeated his biopsy, probably only Gleason 3+3, until he was one of the 3% who metastasized. Now, the key metric here is the negative predictive value, and just a cautionary tale. And is Sarah still here, the radiologist? So I must say, I thought she was a little bit over enthusiastic compared to what the data is, because the negative predictive value varies a lot between studies, from as low as 75 or 80%. In other words, the likelihood that you are going to miss significant cancer is at least 15% in a lot of series. There are ones like Panabianco, 100% negative predictive value, not one negative MRI that turned out to have significant cancer on template biopsies. But most people don't do that well. We don't do that well, although we have a very strong group in this area. Our NPV is around 85%. So you clearly miss some cases with significant cancer. They're mostly 3+4, because if it's mostly pattern 3, the restricted diffusion is going to be limited. But the literature is on fire in this area. There are new publications coming out constantly. We'll have a better handle on this shortly. The other thing is that the NPV is a function of underlying risk. So just to emphasize, the greater the prevalence of significant cancer, the lower the NPV. And here you see for a 30% risk in this just published series, it was 88%. For a 60% risk, the higher risk group, only 67%, which is really not nearly good enough. So there's going to be a continued role for systematic biopsies, in my view, particularly for the patients who are at risk. We just completed this randomized trial of MRI versus systematic biopsies in our surveillance population. It was a multi-centered trial, about 300 patients. And just to show that with MRI-targeted biopsy, we diagnosed the same proportion of significant cancer as with systematic, with many fewer cores. So I think MRI with targeted biopsy is clearly going to replace systematic biopsy to a degree, but there's, as I mentioned earlier, I think there's still going to be a role for systematic biopsies in the patients who have a target. One of the things we found in this study, a little unexpected, was that if the patient had a target, they had a much greater likelihood of having a positive systematic biopsy for significant cancer than if they didn't have a target. In other words, the normal looking area in the MRI was more likely to be positive if the MRI had some abnormality. And just to show that we missed cancer with both techniques, so upgrade on targeted biopsy but not systematic, 6%, systematic biopsy but not targeted biopsy, about 8%, and so neither was perfect. The other area in imaging that is really on fire at the moment, I think, is radiomics, which is correlating genetic features of the tissue with specific subtle abnormalities on MRI. So this is one of the first papers on this, just came out a year ago by Stoyanova, showing that this is different MR patterns across the top, and they co-segregate with molecular features. So, what does it mean to have restricted diffusion with some spectrographic changes as well? Can you predict what the molecular features will be? And there's a great deal of work going on in that area. Michael just gave a great talk about biomarkers, and I'm not going to go into that in any detail except to make a couple of slightly different points. you can't see this, but this is the genes involved in these tissue-based molecular profiling tests. Polaris, GPS, ProMark, and Decipher. And the interesting thing to me is the genes are all different. So here are all these tests that are looking at tissue. There's zero overlap between the genes that are involved, and yet each one of these companies has developed this genetic profile based on kind of winnowing down the genes that are most predictive. So to me, that's just kind of interesting. They clearly segregate patients according to risk. I'm not going to review that. There was the question raised earlier about the actual clinical impact. This is one study that showed the proportion of patients who would, for example, be managed with surveillance before and after the test, or managed with radical treatment before and after. And you can see overall intervention to non-intervention around 15 to 20% of cases, non-intervention to intervention, same proportion. So I have no doubt that these tests have a role. I don't think they need to be used routinely. The typical patient who's got small volume Gleason 6 with a negative MRI or a targeted biopsy that's negative probably isn't going to benefit. The Gleason 7 or the high volume 6s, I think that's where there's a role. The other limitation of these tests relates to heterogeneity, and we heard a lot about this today. But this is just to show two slides, so what a challenge this is. This was just published in British Journal of Cancer that looked at, this is a surveillance cohort, the heterogeneity of Gleason grade group and of ploidy, just very substantial. So and this is P10, DNA, ploidy, Gleason score, some mock-ups of some of these typical cases. So the problem is if you take your biopsy from one area, are you going to miss the heterogeneity that's present? So this is not a new story, but I think this paper is quite important by Way, who I believe was at Hopkins, that they took a small group of patients, so this represents 4 patients who had multifocality. So each one of these guys had at least 5 or 6 different tumors in their prostate, and they did deep sequencing on each individual tumor, and then they pulled out the genes involved in Oncotype, Polaris, and Decipher. So it's really a substantial piece of work on each patient. But what's remarkable, because these are quantitative scores, how the score varies pretty dramatically between the individual tumors in one prostate. You know, each one of these is one prostate with 5 or 6 tumors. Here is a negative score, positive score, and so on. So this, to me, is a fundamental issue for the biomarker folks to grapple with. Now, in their defense, most of the scores are in the same direction, but not all. So once again, tumor heterogeneity is a confounder. And the other reason I think that we shouldn't be doing these tests on everyone is what you could call the Bayesian problem. So you have a patient with grade group 1, favorable features. Let's say he's got a 2 to 3% chance of metastasis at 15 years, which is realistic. You apply the test. If the false positive rate of the test is 10%, then he's going to have a 5 times greater chance of having a positive test, of a false positive test. Or conversely, if he's got really aggressive looking disease with a negative test, would you advise conservative management? So it has to be the right test in the right patient, not just applied in a blanket way to all patients. They've got to have moderate degree of risk, not too low, not too high. And then we also heard a lot about BRCA2, which I think is such an important area right now. And the remarkable thing about the recent data is that it shows in these patients with localized prostate cancer that have germline BRCA mutations, that these localized cancers have such a mutational load that they look like metastatic or castrate-resistant disease. So this basically shows that many of the altered pathways that you normally would see in only in metastatic disease, in the patients with germline cancers, you see them with localized disease. So this has real ramifications for surveillance. We can say confidently that Gleason 6 doesn't metastasize, but you have a patient with Gleason 6 who's got a BRCA mutation, and knowing what we now know just recently about the rapid accumulation of mutational events in those cancers, I think those patients should not be, they should be treated radically. I've heard of a few cases with, in families with strong BRCA germline mutations where prophylactic radical prostatectomies are being performed. But that is still very kind of pushing the envelope a little too far. But certainly if they have any cancer at all, probably should be treated. So we're moving from the current paradigm of initial biopsy, serial biopsy, PSA, fair bit of uncertainty about whether there's coexistent higher grade disease, to the molecular image-based paradigm of much more accurate identification of the bad actors early on, much more rational decision making, much more reassurance to the patient if his MRI is negative or if his biomarker is favorable, and so on. This is now reflected in guidelines. It has been a remarkable shift in thinking over the last 7 or 8 years. Here is the new AUA guideline, but it's consistent with ours. Cancer Care Ontario, ASCO adopted this one. The NICE in the UK, low-risk prostate cancer, active surveillance, preferred management. There's a consensus about active treatment for most intermediate risk, although surveillance for selected patients, particularly the borderline amount of Gleason 4. Where you see differences are in the role of MRI and biomarkers. So we said MRI when clinical and pathologic findings are discordant. ASCO says other tests, including MRI and biomarkers, remain investigational. So does AUA. So none of these three groups have embraced routine use of biomarkers at all, or MRI for that matter. NICE has gone somewhat out on a limb and said all patients should have an MRI. So this is where you have some difference of approach. And if you look around the world, this shows a number of different constituencies. Basically, New Hampshire, Australia, the blue line is the rise in surveillance. The yellow line, Michigan, the music collaboration. Sweden, more than 90% of low-risk patients managed with surveillance. These are 6 different sites in Canada. Some places 98% of low-risk patients managed with surveillance. So there's still a lot of people being treated radically, but not many in Canada with low-risk disease, and I think the trend is clearly in the right direction. The other aspect of this whole thing, and I realize you're mainly a kind of pathology-oriented group here, but just for your interest, is that often these are healthy middle-aged men. The urologist may be the only doctor that he's seeing on a regular basis, so there's also the opportunity to intervene with their general health. They are, after all, perfectly healthy men who've been unfortunate enough to have this diagnosis of what you could call pseudo-cancer. And of course, they require follow-up. But Aaron Katz published this paper called Active Holistic Surveillance, which really goes overboard with dietary advice and all these supplements which are anti-inflammatory and antioxidants and so on. This is just out there. This is what I tell patients. It's simple advice. It's good for the heart and the prostate. They're basically the same organ. Stop smoking, regular exercise, weight management, moderate red meat intake, increase fruits and vegetables. All this is motherhood. Where it gets a little more controversial, statins. This is a whole other topic, but there's really a tremendous amount of evidence now that statins have a favorable effect on prostate cancer, as well as, of course, their cardiovascular benefits. So I'm very strong on this. Vitamin D deficiency is ubiquitous in elderly population in the north and Canada, probably northern part of the US, and this is completely harmless and probably beneficial. And the latest thing is metformin, the old diabetes drug, which has also many beneficial effects. There's a lot of epidemiologic and preclinical data on the benefits of metformin. So we'll be hearing more about that, but I think for patients who want to be very proactive, it's something to consider. So finally, there's the gray zone. So this is, I would say, 15 years ago. There was a massive gray zone. You could treat prostate cancer patients basically however you wanted, and you would never really be criticized. No one seriously treated T1A microfocal 6 after a TURP. And there was, of course, more aggressive disease tend to be treated radically, but I think we've moved to a much smaller gray zone. No one should be treating these microfocal 6 patients, and most of the more higher grade patients should be treated. The gray zone now are the patients with very extensive Gleason 6, particularly in young patients. There's a role for surveillance, but I think we don't have 25 and 30-year follow-up, so there may be a role for selective therapy. The Gleason 7 with small amounts of Gleason 4, I'm not saying they should be treated, it's in the gray zone. The BRCA mutation patients I mentioned, we really don't have data on those yet, but it's compelling. And I think with time, this gray zone is going to shrink further, and the goal is no gray zone. We know exactly what to do for each patient. So I will stop there. I thank you for your attention. It looks like a beautiful afternoon out there. It's been a great meeting. Thank you very much.